bias, objective forum where those folks can share their real life experiences and real world applications. Because there were a lot of questions out there about these emerging technologies. What are they? How do I get them adopted? What's the return on investment? How do I overcome the risk in my company? Where do I apply these? What's the nice to have? What's the must have? So a lot of these questions. So we came up with DCTs Unfolded, and I'd like to begin by welcoming our dear friend, Mr. Tuan Nguyen, and he's become a wonderful friend over the years. They're also a strategic partner with the Boston Global Forum and AIWS, the AI World Society. Was founded about 12 years ago with former Governor of Massachusetts, Michael Dukakis. It's a good friend of ours as well. They have welcomed heads of state, world leaders over the years, White House officials, cabinet level secretaries, renowned experts in technology and AI from Stanford, MIT, Harvard, and others. Professor Tuan was at Harvard Business School. He's a fellow at Harvard K School, Harvard Kennedy School, and co-founder of Boston Global Forum and AIWS. Tuan, I'd like to ask you to come up and maybe just tell, for about a few minutes here, just kind of tell what it is that AIWS is doing, how they're supporting companies in AI. Talk a little bit about the ethics and some of the other things that you're doing with those wonderful organizations. So thank you. Let's give a round of applause for.
Thank you very much, my dear friend. And yes, you see, Celtic after 16 wonderful night, and I just would like to say to you, I have just come back from very significant conference in Vatican, and we have changed to discuss with Pope Francis about AI. Then Pope Francis said about AI in G7 summit recently last week, and AIWS, we are proud from our Boston community with the AI ethics, AI model for a better, safer, prosperous society with AI. And all of us today, and of course David and AKT Health is very wonderful people, organization to contribute to build a new society with AI. We are worrying very much about AI, and we very much advantage of AI. How we can live and work with AI very safe and very good and better society, better world with peace, security, and happy. So that is the AIWS, and why David and our community do very much, and congratulate for our great event, continued series. I have to say, not good, but excellent and wonderful series, DCT series, David make so far. And BCF and AIWS fully support. And I said to you, what thing we said, we talk at the conference of Vatican. I talk about the knowledge platform for AI and how AIWS can contribute in our Boston community to build knowledge platform for AI, for equality of opportunity in AI, for every company, every individual, every country, every religion. And yes, so now our community here very much in startup, small, medium companies with AI. So now all of us contribute to build society, industry for equality of opportunity in AI. So thank you so much for David, and we look forward to your contribution together with us, with David, with AKT Health, with AWS for this very, very significant mission. Thank you.
Bringing a very important element of ethics into this, the government, the regulation, and all of the other areas, so that the human factor, human-machine interaction, and more than just the technology. Let's move into our keynote speech today. We have a wonderful keynote for you today. Inderpreet Kambo, he's a DDS MS principal at IQVIA, a leader in technology and healthcare with a focus on information management and analytics for top life science firms. Holds degrees in science and business management from prestigious institutions. Inderpreet has executed over 300 large-scale health tech programs and published extensively, influencing industry standards. Specializes in strategic relationships with C-level executives and advising on next-generation technologies in the healthcare industry. Let's give it up for Inderpreet.
Thank you, everyone. I don't know if that was true. I really not true. I will try to keep this very engaging. So if you have questions, please feel free to stop me. I would like to have an open and engaging conversation. I can try to keep the last 5 minutes for the questions, but still, if there are questions, just feel free to raise your hands and we can answer. Actually, do I get a mic? Am I audible? No. I will start with some of the facts. We talk about data in healthcare and life sciences, but when we look deeply, how much data is it? There has been a statistics which says every year the amount of data that we produce is more than all the data that has ever been produced. So let that sink in. Every year we're producing more data than we have ever produced in the entirety of our lifespan. However, are we using them? The other research shows that 97%, and again this is more conservative approach, we do not use this data, specifically in healthcare and finance. The amount of data that has been collected over the years, we're not leveraging it. Whether it's unstructured, and again, we will go into some of that immense data. Whether it's unstructured data, structured data, columns, databases, like all that golden words, we're not using it. So what is this big rush about? Let's collect the data, let's use it. Data is gold. We have seen this time and again that the data that we are collecting is providing us really significant value and is providing us insight that we have never been accessed. This is a graph that shows that digital health startups, and again, this is again a conservative approach, but there has been massive startup evaluations, massive startup funding that has been in this whole space of healthcare, life science, digital health. And again, I'm trying to not be specific in one facet of healthcare or life science, just to provide some directional sense of what is happening in this industry. The percentage of funding, of valuations, of data that has been accumulated is growing exponentially year over year. I know we talked about the funding winter that has happened in the last 6 months, 12 months, etc. So keeping that aside, that has to do a lot with the macroeconomics. But if you think directionally, there has been an explosion of data, an explosion of funding, COVID has further accelerated this whole data accumulation. Where does this whole lead to? I talked very briefly about this structured and unstructured data. So let me take a pause, explain what do we mean before we further dive into this. I don't know the details of the audience here, but how deep should I go into this? Or is everyone familiar with structured, unstructured, and so on? So please but this whole data, there are models that are trained on structured, unstructured, and semi-structured data. From tests, diagnosis, to family history, to patient journeys, so forth, to demographics, and this is used across spectrum, from R&D all the way to the commercial. Someone would argue how much is being used on the R&D side versus clinical versus commercial, but I think I was talking to Richard. Commercial and R&D, on the two extremes of it, are seeing the maximum adoption. And the reason is simple and foundational. That is where we see maximum ROI. If we are able to deploy these technologies, these data sets, these insights in these two extreme ends, R&D clinical on one side and extreme commercial, almost like post-commercialization market analysis, they are giving us multi-fold results. And we will talk about it more further. But these two extremes are seeing the maximum adoption of technology and analytics. Questions? We take a pause. Yes.
So, Inderpreet, I do understand there are HIPAA regulations and which will kind of limit people accessing the data. So, thank you very much. So, I'll repeat my question again. Within the life sciences and healthcare, given HIPAA and other regulations, there is not easy access to the data that has been generated. AI and machine learning is data hungry. How, as an IQVIA, you are bridging that gap? And how do you think this landscape will change in the future so that people have a lot more access to the data that they have now?
Sure. Before I answer the question, disclaimer, whatever I say is a personal opinion and not my employer's opinion. Just want to be diplomatically correct. It is completely correct. The access of data is the biggest hurdle in healthcare. But now we're coming to a point where we're talking about clean room. What is clean room? An ability to have secure data rooms where we can combine patient level, patient grade data with the consumer data. So think about bringing lab and longitudinal access data, prescription data, with the activity data of sales reps, or digital data that is being leveraged, a physician going to the websites. Now we are able to secure and combine these two different varied data sets in a secure environment, so you as a customer can run analytics in a safe zone. And that was the biggest hurdle about the HIPAA. How do I access the data, and can I enable data access, analytics, and insights without jeopardizing the whole patient integrity? And I can almost safely assume we have not reached that level, but we have at least started on a journey where now the access to this healthcare data has been secured. We talk about data, you talk about HIPAA, we talk about the access of data, but what is all this data all about? Healthcare is one, I think I was talking to you about this. Healthcare is one fraternity where we have always pushed back on. We will not change. And why? Because we understand the business impact, we understand the clinical flows, we understand the processes, we understand the business questions. There are plethora of questions, plethora of very, very nuanced questions. When we go to the rare disease and when we go to the oncology therapies and line of therapies, it is convoluted to the next level. No one workflow can answer the questions, whether it's clinical trial, whether it's commercialization, etc. So we are bringing those data sets together, the analytics, the technologies, to answer very specific business questions. This is just not a tip of the iceberg. This is just a minuscule level of commercial business case. I can answer the question from disease detection to progression to adverse AE management to hospital readmission. And in healthcare, we are using business first approach or question first approach. What is the homework problem that we're trying to solve? And that's where we start with it, and we reverse engineer our processes to answer these questions. So you asked about HIPAA, or you asked about access to the data. Access to the data in life sciences, pharma, healthcare means nothing unless we know why we need this. And perfect example is, if I do not know whether I need to combine a longitudinal data, patient data, with our consumer data in order to do a better targeting of my physicians, I can combine any number of data sets, but it would answer nothing. We can go into the closed loop claims, we can go to the open closed loop claims. But unless we know what are we trying to solve for, it is not like financial or retail where we can combine the data sets and it will provide some results. Or we have now a data warehouse where we have all the data sets combined. And that is why in healthcare or life sciences, we have this concept called advanced data management or ADM structures, where what is the business question, what is the homework question we're trying to solve, and bringing those data sets together. Before we go further, any questions still? Yes.
I'm so sorry.
Sorry for asking questions.
So if you can go back to the previous slide. AI is relatively new, as we all know, and it's newer in the life sciences space. You have listed almost six areas where I'm seeing potential use of AI. Where do you think the lack more concentration from industry is, where industry is maturing towards AI and machine learning business use cases?
Common question that we keep getting. I think wherever we can automate manual process, and I will not be vague, I will give you specific examples. Wherever I can predict or automate a manual process, that is documentation, governance, scheduling. Those are the first initial use cases which has been proven and are scaling. There are pointed solutions, I think we were talking about this. There are pointed solutions. We can keep debating, will it remove our task force? At this point, it's all pointed solutions. However, when we talk about the governance, the documentation, the manual, repeated processes, the managed care kind of work, those are the first that will go. Because AI has been smart enough with all this ChatGPT 4.0 and 3.0 and whatnot. The moment we remove the hallucinations, the moment we remove the drifts from the models, these are the first use cases that get solved. And we are seeing this live. I can personally attest at least 2 of the top 6 large pharmaceuticals. They are automating every kind of FDA dossiers. We have all these promomats and all these medical legal reviews, submissions, etc. But the maximum amount of time, effort, and energy was spent in reviewing this documentation. And we'll talk more about in our panel discussion. Those are the specific areas where we are now have access, we are able to analyze, and we are able to provide insights in less than minutes now, versus 2 weeks worth of effort. So those are the cases where we are seeing like live, real successes. Just a follow-up from the last one that I was trying to make. Once the use cases have been defined, what are the specific subject therapies, subject areas that we are trying to define, and going back from that, that is a foundational success criteria in healthcare life sciences. It is difficult for someone who is not in healthcare, and I'm sure all of you can appreciate this, but someone who is not in healthcare life sciences, the first knee-jerk reaction is, why don't we get all the data? Just get all the data in a data warehouse or big schema, Snowflake, Databricks, and we can start solving questions. It doesn't work this way. And we have seen failures over failures. Large enterprise, small biotechs, doesn't work this way. So we are defined, and that is why also I have personally seen even large pharma having multiple data warehouses. A patient data warehouse, claims data warehouse, a digital data warehouse. And the reason is simple. It is too large, too complex to solve for this. I will just skip through some of these and running late. This was one case study I really wanted to emphasize, and I think this goes back to your question as well. What are those pointed solutions versus overall solutions that we are trying to deploy and implement? Wherever AI can support or augment a decision making, that is the first use case that companies, healthcare or life science are trying to focus. This was one of the case study we did where one of the large pharma, they wanted to understand the burden of care for diabetes, and they wanted to predict better, better than the ICD codes, better than the CPT codes that were available. How can we find those patients? Can we create the burden? We were able to cross and create an ROI between $2.5 million, say $1.5 to $3.3 million of sales based on the symptoms, based on what the physicians were seeing as in terms of patient symptoms, as well as the tips. These are pointed solutions that I spoke about initially in my discussion. That using these very point-blank solutions, we are seeing this AI being deployed for success. Again, these are not scalable, these are not large enterprise-wide solutions, but these are providing those ROI that we keep talking about. Can I use AI to provide my ROI and test these use cases? I'll skip over this, I'm short of time. But AI and GenAI, or these advanced technologies, they also come with an inherent tech and healthcare specific challenges. We can talk about the technology per se, like LLM, and we talk about this more in the panel. Why are some of these models not working? What is the issue with LLM? Healthcare specific LLM. Is there a healthcare grade AI? Is there a clinical grade AI that could be deployed? What are the issues with transparency? What are the issues with hallucinations? What are the issues with inconsistency? How do we go past this? And the biggest issue, regulatory. If we go back just a few years back, not even a decade back, everything about regulation was around software as a medical device. However, in today's world, everything that is being developed, digital health, AI, software, none of that fits into SAP. As a result, NICE from UK, our FDA, our PTC, everyone is trying to provide, even Biden came a few months back, the US government provided a guideline, soft as well as hard guideline on what would entail a safe and regulated AI.
Great presentation, and especially on this. Great presentation, especially on the topic of hallucination. That's where most healthcare companies are struggling with trying to kind of use generative AI. So we have to type it again. So my specific question is on the medical doctor training as well, and there is always this specific uniqueness when it comes to the patient. And some of the things that could be kind of generalized as a garbage from other data sets or points could be like a very important and crucial variable or token that could be taken for a specific patient. But one challenge from the AI perspective is that like this has the generalization or over generalization, kind of like creating one model fits all type of approach. So how do we kind of like balance that? How do we keep on making that uniqueness, but at the same time, how do we kind of like build a pipeline which will satisfy multiple?
And that's a very common issue that we see. I don't think we have an answer yet. The hallucination that you're talking about is because the models are trying to befit all the different use cases. And I keep going back. Healthcare is use case specific first. Rare disease, I don't think there's any model that can fit both chronic CHF or diabetes, and we can fit that into an ultra rare disease like spinal myopathy. I don't think there is any. The moment we try to create those, it will start creating hallucinations. And that's the reasons why when we deploy any AI model, we start with use case first, but then we create healthcare specific canonical models.
The part of it is like you have to start with the end in mind. Like what is the goal?
It's what's the goal?
What's the goal? Because there's no, you have to reverse engineer to a certain degree.
And that's the mantra for success here. We cannot create models that will befit 2 or 20 different use cases. What is the thing that we're trying to solve? Can we create the scale? And that's where, for all the failures that we see, that's the recipe for disaster. And I'll just end with this. We have proposed solutions. We are trying to provide, whether it's a hallucination issue, whether it's a validation at scale issue, we are trying to solve these. But it will require time. It will require time to improve the accuracy. It will require time to remove those hallucinations. And most importantly, what we keep talking about it but missing is how do we collaborate between the expertise that we have a lot of experts here in the room, clinical expertise as well as whether it's clinical trial or healthcare or life sciences, bring that expertise into the picture, get their validation, and then scale.
I have a follow-up question, and by the way, very good presentation. So, I mean, these problems have been discussed for the last couple of years, and new methods like using RAG to actually improve the accuracy locally of your model. But in doing so, you're also actually isolating your solution from the outer world. How do you see this actually? Is it really a solution or it's creating other problems?
I don't have a solution there's no pointed solution. It's a chicken and egg issue, specifically in healthcare, because we're trying to find a solution for a use case, but then at the same time, we are trying to create scalable solutions that we build. What we have seen anecdotally is creating groups of these use cases that can follow a prototype or a theme that answer these questions. And the most common among those is not from technology perspective, but more from a scalability perspective. Rare disease, oncology, ultra rare, they all get clubbed together. If you talk about patient journeys, they all get clubbed together. So it's what we call subject areas in healthcare analysis. It's clubbing all these models, hallucinations, issues, canonical models by these subject areas. And that's what we see in a lot of areas.
And that's just going to thank you for explaining that. I think the rule of thumb is if you're looking at it, there's no such thing like an enterprise level AI model. Because when we have to start with the AI in terms of can you actually train a data set to actually provide some generative AI or predictive AI. And training data set has to be tied to the knowledge, the subject matter expert aspect. So if you're thinking about one disease and you start expanding into other disease areas, you get hallucinations, model drift, or model decay. So anytime you see an offering of an enterprise level AI, be very, very cautious because that's not something that we are at this stage depending on where AI is and what the level of training that's needed. ChatGPT is very different and medicine is very different.
I think this is a great presentation. I have had a little dabbling myself in the whole AI, generative AI space last year. Worked with a guy in Detroit who had a way to streamline post-discharge patient care. And the first thing we noticed was that if you had a large body of documents, hundreds of pages of IQV best practices, the GPT chat was able to synthesize it down and you could really get your arms around a large body of information. Now, when you have that, there are no hallucinations because you have a confined body of work. What he was exploring was if you work with a hospital or a provider and you're trying to refine better and better techniques and you use the chat to give the patient answers, then it's still coming from a more contained area. But like when you open it up to the internet, you know.
So you define the classical case of subject area. So if you say this hospital readmission or discharge, in this case, is a subject area, subject theme, and what you created was an AI agent that was using this wealth of information, a concentrated wealth of information to answer the specific questions around this discharge or readmission. But if I try to do either I try to extrapolate this to different practices, like not from hospital to hospital, but hospital to IDNs or IDN to biotech or whatever different practices. Or secondly, if I change the subject areas from readmission to, let's say, nosocomial infections, that is where you start seeing hallucinations. Because now you made it cross subject area.
Okay, I think we're about that time. Thank you, wonderful discussion. Thank you, Inderpreet, for beginning to help to shape our mindset with these ideas. It's wonderful. So we've got a 5-minute break. Bathrooms are out the door to the right. Multi-gender bathrooms, sinks in the front. So we'll see you back.